Hello, welcome everyone to the second meetup of the Techies in Health community. My name is Adriaan van der Velds and I will try to be your moderator for today. The topic of this second edition of our community's meetup will be around standards. But before we go into the particular meetup today, for those who are not familiar with the community, let me give you a bit of context, backstory, how this all came together. As you all might know, Techies in Health is a community for people either working or that have an interest in the application of technology in the healthcare realm. So we have a main focus on developers, but actually anyone who feels that they can use their skill or interest in tech to further advance the healthcare industry. Last time we had our very first meetup with speakers from Dmhd, Lucy, HealthTech, and FHIR Health to share our experience and views on health tech. And what came out of that very first meetup was there is an interest and a need for more standards to be used in the interoperability realm of health tech. And that brings us to this meetup today. Thank you all for joining, because we have some very nice content for you guys lined up, where we have experts in the field from 3 companies that will give a talk on their topics regarding standards. These will be speakers from FHIR, Quinn, and Founda. To maybe give a bit of practical information, as you might know, initially this was intended to be a hybrid meetup, but due to new COVID measures, we've opted for an online edition. Today, I'm very happy to have you all online on the Zoom call. We will start off with 3 presentations, and in the end have a panel discussion, and anyone who has questions can leave them in the chat, and we will try to cover those. I think I would like to stop there and start with our very first presentation.
Yeah, we're on. Well, again, thank you for inviting us. It's nice to be part of the techies in the health community. And I've watched the recordings of the previous meetup, which had a nice energy, and we already heard the F word quite some time. So it's very nice to be here and talk about FHIR. And we will start up by giving a very crash course of FHIR, of what it is, and how it's applied in the Netherlands. And we only have so much time, a very limited amount of time, so we will skip a lot of important stuff. Normally we can talk about this for, well, days actually. So for some things we will go too fast, for others we will not get into the details, but it will hopefully provide us with a nice baseline for having, well, good questions and a nice discussion afterwards. So without further ado, let's introduce ourselves. I'm Ardon Toonstra. I work at FHIR as a FHIR consultant, mostly specialized in helping customers with their with applying FHIR to their needs. One of my biggest assignments over the years was working at the Netherlands, where I am involved in creating FHIR for the Netherlands information standards. Marten, do you want to take over?
My name is Marten Smits. And I am, also work at FHIR. I'm a software developer, and last couple of years I've been mostly working on the .NET SDK. Yes, that's the software development kit for .NET, where we mainly implement FHIR. At FHIR, we proudly call ourselves the co-creator of FHIR. We played a key role of the development of FHIR itself from the very beginning. And we are the owner of Simplify.net, the organizer of FHIR Dev Days, and the developers of one of the first FHIR native API platforms, FHIR server. And it's my job today to give you like a 5-minute crash course in FHIR. So good luck with that. This is this is not FHIR. This is Hl7 V3. Some of you might recognize it. And when people talk about Hl7, most people think about this format. It's Hl7 V3, and it's one of the most I think popular standards in healthcare. It's like millions and millions of messages of these go through every hospital every day. But it's not really helpful to exchange between different hospitals. So when Hl7 talked about, I want to exchange between different hospitals, they first thought about V3, which was really complex and really, expensive to implement. And then they had took a step back and they thought, hey, if we can start all over again, what will we do? Now, that was when FHIR was created, and FHIR is actually a standardized API for healthcare, which has its own data model and its own REST interface, where we will talk about a little bit about today. First, the data model. The data model of FHIR exists mainly from different small resources, which are like building blocks of FHIR. And examples are, for example, procedures, allergy intolerance, patients are all like individual building blocks living somewhere on a server, which contains information describing those components. These building blocks can also link to one another and each other to actually make a web of information. And this is an example where this is done in a procedure. The procedure building block itself contains data from the status of the procedure. Is it already been performed? Will it still happen? But it also links to stuff like who has performed it, and that links to another resource which contains information about that particular practitioner who has its name, its organization, etc. Also to the subject, to maybe a report where it's been documented, the procedure, what kind of reason led to that procedure. That stuff always is also captured somewhere, but it all lives in a different resource, and you can be queried whenever you want. It's really a little bit of theory here, but I think everyone wants to see what this look like. This is an XML example of a resource, and I think this is, I can see it's a procedure, and these resources contain of a little bit of metadata, which is mainly about the resource, where does it live, when it's created, what kind of ID does it have, and then there's human readable text, where you can always rely on when all else fails, there's always HTML. And this is, I think, the most important part. This is where the structured data lives. This is below the narrative. And that's where these statuses of the procedures, the code, the patient, the date, etc. all lives. And after that, there's always extensions. So when something doesn't fit inside of the standardized FHIR data model, you can create an extension and add it to that resource, so you can, which you can then use in your really specific use case. And for the people who think XML, what do you live in the early 2000s or something? There's also a JSON format, which I personally prefer because it's way more readable and way more flexible. And then there's the REST interface, which is, I think, the power of FHIR, which makes it an API. Every resource lives on a FHIR server, which is an endpoint. For example, here's generalclinic.nl/FHIR, which is where the FHIR server lives. And then you have the resource type and a resource ID, which you can use to query different resources. You can just put this in a browser if you like. You can do this at home, you can do that after, and then you can actually get patient information back. But you can also use it to like search for different patient information. For example, you can have, if you want to query patient's blood pressure, you can see this below here. And then you can just query for a LOINC code here, and then says where the subject is this patient. And then you can get all the patient's blood pressure back. Now Ardon will explain something about, it's also like FHIR in 5 minutes. If you want to read more, please ask. But Ardon will will explain a little bit more how we use FHIR in the Netherlands itself.
Nice, thanks Martin. As the picture shows already, like I think here in the Netherlands we like FHIR, especially the people in The Hague, and also the people that govern our country, because over the years they have put out a lot of programs that try to provide incentives for healthcare providers to actually increase interoperability in the healthcare domain, and they are called VIP arrangements, or like subsidy programs, and there are a lot of them, and I think there are 10 or something like that right now, and they all target a specific area in healthcare, and they all try to let the healthcare provider implement certain information standards in order to achieve the healthcare interoperability. And the healthcare providers get money for that once they comply to those requirements of implementing the information standards. And if we talk about those information standards, then we have NICTIS in the country, which is a non-governmental standardization organization in the Netherlands, who maintains most of all the information standards that apply to the healthcare domain. On the screen you can see certain projects or domains where healthcare information standards apply. If we zoom in a little bit more, if we break down the information standards, then we can, the definition for an information standard as NICTIS would use it would be that it concerns a bunch of agreements between the stakeholders of the information standard that would include a data set that describes which information will need to be exchanged, and also when, and what the triggers are for sending such information, which is all covered in a functional design. And it will also include an exchange standards, which can be version 2 or Hl7 version 3 or FHIR. And over the years, those information standards have become standardized itself as well, using ZIPs or zorginformatiebouwstenen or healthcare information models. Either way you want to call it, but for now we will just call them ZIPs. And those are reusable building blocks of functional information that can be used to build the information standards at NICTIS, so that the implementers of standards will not have to implement a patient differently if they are in a different healthcare domain. Over the years this has been applied. So here on the slide you will see a couple of information standards: the patient summary, the GGZ standard, or the e-care, overdracht standard, or medication process, with the number of ZIPs they are using and the overlap between them. So you can see they are reusing those bits of information. If we zoom in a little bit more, here we have the actual ZIP, which is a very important part of the standards that are being used in the Netherlands. And it's very good to know what it is and what it is not. So the ZIPs are actually a kind of a logical model, and they describe on a functional level something about a healthcare related concept, like a blood pressure, for example, or in this case an allergy intolerance. And it states, it has a web page on the internet on zips.nl or zips.nl/wiki. And it will contain a description of what we mean by blood pressure, followed by a UML diagram in the middle that contains every concept that a group of different healthcare, group of multidisciplinary team put together, describing, for example, that the blood pressure has a diastolic measurement and a systolic. And we'll also describe the cardinalities, how many times a certain concept exists. It also has terminology bindings, which codes to use for certain measurements. And this is all pretty conceptual speaking, because the zip itself does not tell you, for example, how to store that information or how to send it to someone else, or when to send it. They don't contain any use case information, because that's provided in, for example, the information standard. So they're very useful for defining an information that belongs to a concept, and can also be of help when, healthcare providers need to register certain concepts, so the systems can provide support for that. So now this is all logical speaking, but because the zips are such important in the Netherlands, we also have created FHIR profiles for them. There's one thing I forgot to say about the zips. They are technologically agnostic, or meant to be technologically agnostic, and they should survive the FHIR standard. They're made so that after FHIR, they should still be applicable, because conceptually speaking, a patient will always have a birth date, no matter in what exchange format you will represent it. So the zips, important, and we have created FHIR profiles for them to actually say something about how to exchange them. And FHIR has a very nice method for it, because FHIR itself is an international standard, and it has a profiling method where you can take the international FHIR standard and describe it for your own use case in a structural manner as well, instead of writing it down in a PDF file or whatever. And those profiles are actually, well, the goal of those profiles are firstly to document and communicate the certain rules, the specification of where you want to apply your standards. But because they are structured, they can also be used for validation purposes. So what we've done is, for a lot of zips, we've created FHIR profiles, and those are being published at Simplifier, which is a global collaboration platform to work together on FHIR profiles, for example, and also to publish it. And we have mapped every concept of a zip to a FHIR resource and FHIR element, and provided traceability within the profile back to the zip. So if you open the profile, you will find a mapping inside of it. But over the time, we've created a lot of FHIR profiles for all kinds of versions. So just Googling and getting to your FHIR profile is not the best way, because you might end up with using the wrong version. In fact, you would probably always want to implement based on an implementation guide or the information standard. So once you start out, you need to navigate through the information standard to the right profile to get to the right version. And besides, thank you. Besides the generic profiles, an information standard can also have specific FHIR profiles designed, which are being included in, well, the technical design or the implementation guide. And this together forms an information standard, but that may not be enough, because you'll also need to make agreements on, for example, which infrastructure to use, or an exchange framework like MedMij, which adds another layer of additional specifications you need to comply to. For example, all kinds of stuff about authorization and authentication, or legal stuff which may or may not be inside the information standard. So in the Netherlands, we have a lot of different programs. Well, MedMij is the one I called before, that tries to enable information exchange to the patient. We have Baby Connect, e-overdracht, and so forth. But we don't have time to go through all this. What I do want to mention is that if you start out implementing, please be aware of the chat.fhir.org, which is the international community place for questions and helping each other out. And we also have a Netherlands stream there. So if you have questions about technical questions, not things about PIP and a subsidy arrangement, please go to the chat.fhir and you would likely get help very soon. And lastly, well, we have Dev Days. Just want to give a shout out, which is maybe the bigger brother, the big brother of these meetups. So be aware for next year. So thank you. I give it back to Adriaan, I guess, for maybe there are questions. I hope we were on time.
Thank you, Ardan. That was a very nice introduction to FHIR. I'd like to invite you to join us here, so we can maybe answer some questions from the audience. If anyone has a question who is tuning in, please feel free to type it either in the chat, or if you want to ask your question directly yourself, we can also try to give you the floor and ask it directly. If or while we're waiting for questions from the audience, maybe I can kick off with a question. This was, I think, a very brief introduction to a super big topic. Let's say if I were a developer novel to the project, and I have a HealthTech application, and I really want to start with something simple. I want to, for example, be able to get the name and simple demographics of a patient in my application. Yeah. Any advice on where I should start?
Well, first there's I think there's a really nice there's some really nice example programs on GitHub. I can share the link later, where there's just like with Java and .NET, I think, some really short examples on how to basically exchange patient data using a FHIR server that's openly open. There's a lot of test servers there you can use. So I think that's a good way to start. And the FHIR specification itself is also freely available for everyone, not like Hl7 V3 or anything that you don't have to be a member of Hl7. You can just Google for it and you'll find it. And I think there's a lot of explanation there.
Yeah. But you can get lost because, well, it's pretty big. So maybe I could also advise to, well, have a training. They're out there, or come to meetups like this, and or the chat.fhir.de or the chat exactly for questions.
Thanks. And if I'm not mistaken, FHIR also organizes trainings like these, right? Awesome.
And also Hl7 Netherlands. Hl7 Netherlands also organizes FHIR trainings, which are on a fixed date. So
yeah. In the meantime, checking the chat if there are any questions from the audience. If not, I see also our second presenter is ready. So then please also, if questions do come up later on, as a reminder, we have the panel discussion at the end where you can ask everything you want of our experts. Now, without further ado, our second speaker of the day.
Maybe we have problems with the audio. Should I start over? Hello, my name is Gabriele Di Stefano and I am the technical director here at Founda. Together with the development team and the product, we are creating the product solution of Founda. Today we're talking about standards. Standards are a big thing here at Founda. We really believe in standards and we're moving them forward in our proposition. Thank you, Adrian, for hosting our meetup today. And a big welcome to the people that are here, but also for everybody that is remote. So I'm here to talk about how Founda makes usage of standard in its product proposition, and how multiple standards can also work together seamlessly and in harmony. The company goal is to facilitate the creation of connectivity and connection between applications and provider organizations. We expose a uniform solution that hides the technical complexity in creating an integration for such an actors. We do this by exposing a healthcare gateway. The healthcare gateway for us is a software that sits in between healthcare actors and allows an application to communicate with the provider organization. It can do it in a one-to-one way or in a one-to-many way. The healthcare gateway supports two types of flows, what we call the pull flows. So when a message is originated from an application and then through the gateway is forwarded to the organization. Or we also provide the push flow. So when an event is actually originated from a organization provider and it's then broadcasted using a subscription model towards all the applications that are listening to that particular event type. As an example, today we have the Triant Hospital using the Nexus system, and it's onboarded in Founda as a provider organization. And on the other hand, we have the online prompts as application. What Founda does is enable online prompts to create questionnaire based on events that were triggered from the hospital side. From the very beginning, it was very important for Founda to understand that all these actors already made technical choices. They chose the vendor, and they chose the system to work with. They chose the protocol, and they chose the data format to work with. So that's why at Founda we decided not to reinvent the wheel. We did not want to inject yet another standard into the industry. But instead we decided to adopt, use, and leverage existing standards. We first started with the one that for us have the most and the largest coverage in the industry. We started with Hl7 V3, FHIR 3, FHIR 4, and we're working on XDS XCA as we speak. We're also currently making room in our design for future adoption of standards that maybe not be there already, or of new version of standards that we already use. So very good. Now Founda is technically capable of exchanging messages between two different actors. One may speak FHIR 3, one may speak Hl7 V3. And we take care of the complexity and the interoperable engine that is required for these standards to speak one another. So if you look online at our documentation, you will see that there is a FHIR specification that is exposed through our API, and we do it in a multi-tenant way. So we do it on behalf of a provider organization. But this is for Founda only the first layer of standards that we use. We decided that the raw exposure of FHIR through our API was not enough. It was only the first step of our journey. The second layer of standardization Founda provides is an abstraction on top of these protocols. I'm talking about the IHE profiles. Founda decided that going forward, for the new functionality that we were going to create, we were going to base them on the IHE profiles. They describe the interaction between the actors, the interaction between services and components, and explicitly coordinate the usage of FHIR to cover use cases. So today, in our roadmap, we have the PMIR profile. And what it is the Patient Master Identity Registry. So that is an example of the functionality that we offer. So we have multiple actors in the chain that would like to exchange information, but it's natural for this system to identify patients with different IDs. So how can they communicate one another? Well, Founda offers, as a solution, a master registry that takes care of this complexity. But the parties that want to communicate will not have to take care of that. This is hiding complexity. And we do it by following the procedures on this profile that is called PMIR. Also, the profile tells us that we should enable application to subscribe to events of patients that are going to come from the provider organizations. So we are implementing the standard. It's a well-known guide that other actors may already know. So what we're doing is we're facilitating the communication by getting closer to the healthcare actors. Another standard that we're implementing is Dmhd. What this profile tells us is that we should expose patient documents. How? Through FHIR APIs. So we are exposing FHIR endpoints for the searching of patient documents, for the describing of patient documents, for the downloading of those documents, or even the uploading. We also implemented the ATNA, which through FHIR endpoints still enables the viewing of audit logs. It tells us on how we should store these logs using standards, and also provides actors not only to view the logs, but also to store logs themselves. And we do it in a secure way, so that we enable both the application or the provider organization to have their own logs. The journey is not finished for us. We would like to cover as much as possible of these IHE profiles in our product. So for the future, we're going to work more on XUA, IUA, and other profiles that are going to come our way. Thank you.
Thank you, Gabriel, for that very clear presentation. Could I invite you to join us maybe for some questions, either from the audience, and otherwise I'm sure we will have some questions in this group. I will switch over now to the group audio so that everyone can speak directly into the mic. Let me start maybe then with a first question. You mentioned there are next to the FHIR standard we learned from Martin and Arden, there are even more standards yet out there, and then there is IHE also. How do I, if I were to be a developer again and want to build an integration, how do I make a pick? Which one do I choose?
Well, at Founda, they are complementary. That means that our foundation is FHIR. So that means that to create the connectivity towards FHIR, which then forwards the request to the appropriate organization provider, you have to speak FHIR. What the IHE profile is a coordination on how to use FHIR and what is the flow to use FHIR. So IHE itself covers use cases. And it tells us that in order to achieve what we want to do, we may have to call a sequence of FHIR calls, FHIR endpoints, maybe in a sequence, maybe over time. So the answer to that, there is really not a pick, they're complementary. We may expose IHE profile that actually use one or the other standards or versions of it. So today we're talking about FHIR, specifically FHIR version 4. But we may have use cases in the future that use R5. And as a Founda platform, we are going to support them both.
Thank you. Do you guys have another question, or otherwise I have another?
No, it's very clear. Thanks.
Great. Up to now, we've been really talking about the technical sides to standards. One of the purposes of the Techies in Health community is also for developers to employ their knowledge on technical topics to benefit healthcare. Do you have any view on how standards help, in the end, a hospital or a doctor in that hospital?
The usage of standard is a benefit. For the particular usage of that to a doctor, I would say that maybe the simplification of systems that use a particular standard facilitates the multitude of software that are available to a doctor. And the transmission of data between these systems can be much higher facilitated by the usage of standard itself. So I would say that for the end user, which is a doctor, standards are extremely beneficial. That is also why, that's the reason why Founda adopts standards by design and decided not to create its own.
Okay, very clear. Thank you. I also see that our next presenter is lining up.
I have to leave the mic.
We do a quick mic check. As I said, this is our second. And I think we're good to go.
All right, we'll be here today with an edition of Tales from the Fire Brigade. So yeah, we heard some theory already. We heard a little bit of practice, but also at Quinn we have been using FHIR for real, in anger, as they say. And I would like to share a bit of that journey with you today. So first, a little bit about myself, what's relevant for this talk. So in fact, I started with standards early on, communication protocols in the telecom sector mostly. I spent 16 years, so a little bit more in healthcare IT already, in a company called FHIR. Well, FHIR was kind of the prototype company that Founda is now also taking the same approach, like taking standards very seriously and designing components for interoperability to make a healthcare exchange a bit more easy. And during the journey with those profiles, I learned a lot. And today I would like to kind of introduce, like, FHIR is currently really the best bet you can take. And one of the things that I indeed did when I arrived at Quinn was to really evangelize the use of FHIR. But of course, there's also some things we learned along the way. So, yeah, I would like to start off with the fact, like, there's so many standards to choose from, and if you don't like them, you can just wait another year. In fact, for FHIR, you could say that the waiting has been worthwhile. And in fact, like, if you're now in healthcare IT, you might see, like, FHIR is still a very complex standard, but if you look where we came from, like Edifact, well, it has lots of pluses, you have to admit that. But other than that, it's like, yeah, a very difficult structured format that cannot carry, like, the complex data elements that are required in healthcare or in health tech contexts. So it is metvrij, so that's kind of a play on a modern standard, but other than that, I would skip it unless you really have to integrate with legacy systems, but Founda can do that for you as well. Then we have Hl7 V3 already displayed before. One of the big drawbacks, I think, is it's a closed specification, so it's pretty hard to find the proper information about it. And there's as many dialects as there are users, so you'll always need communication engines and what have you to make sure that your message is understood and processed correctly at another hand. And it's very much point-to-point as well. And then we have Hl7 V3, which is kind of, a very thorough, ontology-driven, spec-driven approach to improving Hl7 V2. But it was kind of, such an academic exercise that even writing a specification
it would take years, and we know the project that didn't really start off or end well with Hl7 V3. So you can model the world in it, but probably you need a couple of petabyte storage to actually do so. So then along the way, I think Hl7 FHIR came about, taking the learnings of many years of Hl7 V2 and V3, and kind of using the data modeling capabilities, but taking a pragmatic approach of Hl7 V2, taking into account the issues with the dialects by introducing profiles that were already briefly mentioned. So as you are a health tech company, you can learn so much just by reading the specifications or following a training. There's a great community. It's built on modern standards. So it uses HCP. You can do proper security. You can have OpenID Connect integrated, OAuth. So there's a lot less pain than with the previous episodes of Hl7, so to say. And as you see, like many platforms will need to integrate with external services. No company these days is really an island or a silo of data. Everything needs to be connected and real time. So in that sense, just not using FHIR is really a missed opportunity, because that's really the best way to go about. So my intermediate conclusion is no one ever got fired for choosing FHIR. So when we started defining the first use cases for the Quinn platform, we really took the idea we need to interconnect with partners. We need to probably expose our data through FHIR very seriously. So FHIR was already kind of pre-selected as a very important part to take into account when modeling our data and when doing exchanges. So I don't have a lot of time to talk about Quinn, but I can simplify its mission to objectified healthcare. It's building a platform to reduce visits to the GP by improving the communication between patient and healthcare provider, and reduce the number of specialist referrals. We do so by kind of taking a standardized approach to leading patients in a treatment journey. We have some tech problems, I think. Okay. The mobile app provides self-care possibilities, so you can do symptom checking and monitoring. And if a complaint is serious enough, you can discuss it with your GP through a communication platform. If you really need to be treated in specialist care, there's like a standardized care pathway that can take you through the following steps. Reducing handovers, making sure that information is always automatically at the right place. And for in the future, we also try to do like treatment follow-ups and stuff like that. But the main building blocks we have in place right now are the self-care, GP care, and specialist care building blocks. So we started out with building a simple symptom checker, and as a good startup, you first have an MVP, or actually we started to call it minimal lovable product, MLP. So you have a couple of developers. You just take an open source FHIR server, you map the data to FHIR, and you store the medical record data in the FHIR server. And basically, that's done. You can just point the developers to the FHIR specification, and all will work nicely. So as you can see, here's a very early stage of the architecture, which consists of also a component that chats with the mobile app. And then there's a back couple of backend components to deliver the medical content, which consists of articles and questionnaires. And the HealthTech API we leverage for storing all the FHIR resources. And of course, by now we have many more APIs, but this was kind of the first basis. So then we fast forward 2 years. What we are seeing now is that our platform has grown a lot. So from the 3 developers in the beginning, we now have 51, of which many are from different industries than healthcare IT. So they all have all kind of very relevant questions and comments on how things are done in Quinn. Like FHIR is slow, how do I get this in my FHIR resource? Why do I have to use FHIR internally anyway? We have many connectivity points to FHIR to store very different elements of the app, and later the GP portal that we built, Quinn Pro product. It was time to kind of revise our initial ideas and see what we could improve. So, of course, the solution is to form a FHIR brigade, as we did. We organized a workshop. We got external consultant to help with us from FHIR. We gathered the stakeholders that had been working with FHIR APIs in the company the most, and we started to analyze what was causing the questions for the developer sentiments with FHIR. Because I was still kind of convinced that we were taking the right path. So, what do we need to change? So, one of the outcomes was that, especially when you grow as a development organization, and we don't just consist of a product team. We also have a big research and development department. There's like many different stakeholders in Quinn, so we need to work more formally together and start to standardize things also internally. So one of the things that we ran into is you can store FHIR resources as is, as you like in the FHIR server, but you kind of need to restrict what you put in, unless you will get very much data drift in your FHIR server. So you need also to use FHIR profiles internally. So that's not something that's just something that's needed for the organizations like MedMy or NICTIS. Also internally you would need to standardize your resources. So that's not really a developer's job or even a business analyst's job. So our approach is now to involve specialists to do this modeling of medical data, and then have the developers just focus on what they like to do most, which is writing code and getting stuff working. So the other part is, still it's important that developers kind of know the data model of FHIR, but there's a couple of things that are quite complex. As you can see, FHIR is a kind of graphy structure. It has lots of references to other resources. So if you do searches, you need to include information from different resources. So there was lots of questions on how to do that efficiently and prevent queries that are super long, or prevent access control rules that need to be applied over many different resources. So the understanding of compartments is very important, and also just knowing the specific FHIR implementation that we use, the FHIR server. That's also something you cannot do without if you want to improve the system. So we kind of wanted to take one step towards the standard working mode of the developers, which is to develop Java-based APIs in Spring Boot specifically, but still keep the FHIR burning. So we brought a new life to the FHIR facade pattern, which is often mentioned as kind of the pattern to expose legacy applications to the outside world. This allows us, if introducing FHIR facades, like you have your own data model, you expose it through FHIR, and that way you can already ensure compatibility with FHIR from your early API development, while still using your own entities and have all custom data elements that you need to have a proper questionnaire flow of or whatever is your use case. And the other part is, we focus on what we need to kind of exchange with the outside world. So, of course, if there's more extensions than real attributes, having it in a FHIR resource doesn't bring a lot of value. So, keep those data attributes private is our way to go now. So that's kind of what I wanted to share. If you have more to ask or to comment, you can reach me at this email address. And of course, you can also ask questions. This chat over there. Yeah. Thanks.
Thank you, Walco. That was a very nice talk. I fully appreciate that everyone is really. It is a short time to cover all the information that you guys have. I hope this is a small teaser for the audience, and I guess there will be many questions. So if you have any at home, please ask them in the chat, so we can cover them now, and otherwise reach out later. I think it's become a tradition now, ask a question straight away. You mentioned that Quinn is particularly focused on GP offices, or GPs, I should say. GPs and patients. All right. So standards being the topic of the day, is there a difference in how standards are being used in, let's say, first line care compared to second line, or are they more universal?
No, there's definitely a difference. So in GP care, like 80 fact examples that I showed are really still in quite common use. That's where we have to work with. But of course, that's not really what we do internally. In second line, there's a lot of Hl7 V3, of course. We're building, for example, integrations with radiology diagnostic centers. They use a lot classic DICOM, classic Hl7 V3. Although we see some movement, like, okay, maybe we can step up our game, and also in the DICOM world, new standards have been DICOM Web. So there's movement, but usually if you want to start tomorrow, this is what we have, and that's what we often work with. So I think that's also why partners like FHIR can be really very helpful in achieving those integrations as well.
When you say there's movement, the standards, especially the newer standards, they are quite novel. Do you have any thoughts on what is limiting the speed of adoption there?
Yeah, so I think it's mostly just the development capacity or capacity at the IT departments of hospitals, and the ability to run projects. So I think they're quite often just working in the with projects that are already like incoming, and then the innovation roadmap gets a little bit pushed back. And although there's some good examples, I think, where I cannot really name them, but there's some examples where really they want to move to the next level, where they really have provided like a communication API based on FHIR already, like for the whole hospital, which I think is quite impressive. But it will take time. It will take time. Yeah, especially, so given like the facade pattern that I mentioned for legacy applications, the more like the original data is in a very different, modeled in a very different way. The more difficult it is also to expose it to external.
And to make it restful, it's also very hard, right? To give everything a nice, good, consistent ID for the resources. So that's what we also noticed, that making the information standards for MedMag, that there are still a lot of old legacy systems that it's very hard to make them truly restful. So a facade is sometimes applied.
Maybe this makes for a nice bridge of moving from the questions from the specific to the presentations. Let me quickly check if there are any particular questions to the last presentation of Walco. I think I see a question from Freek from Polen. I think that makes for a good first question to ask, I guess, in the broader group. I'd like to remind everyone at home, if you have questions or statements you'd like to challenge our panelists with, feel free to type them, and we will try to cover those. To start with the question from Freek, how do IHE profiles and FHIR profiles relate? Anyone wants to jump on that question?
Yeah, I think I can. I think it was already answered briefly before, but I think IHE and FHIR complement each other. So IHE profiles mainly describe how to use other FHIR profiles in a particular use case. So IHE profiles mainly describe how to use specific FHIR profiles to accomplish a really specific task. And I think they really complement each other, because that's something that FHIR really misses. But IHE profiles can also use other standards to describe another use case. For example, they can talk about T3 or talk about T2 or DICOM even.
I think they always have a certain use case that's being described. Well, a profile by itself is just representing a certain data model.
Which profile are you then referring to?
Just a FHIR, yeah, exactly.
The naming is very confusing.
So in my mind, it's always a FHIR profile, but it's very confusing that they use the word for different.
Like you said, it's true. Like the FHIR profile only defines a certain data model and not how to use it.
And in FHIR, that's happening inside an implementation guide where I describe we're going to exchange this with these search parameters, which could be kind of the equivalent of an EHI profile, but mostly those EHI profiles.
Yeah, so new IHE profiles are really implementation guides of
FHIR. That's maybe the best relation.
I think that's where where they're moving. IHE never wanted to reinvent the wheel, so they use existing standards, but say how they are applied to a certain use case, the defined actors, and make sure then that it's also testable and a connectathon that it works like that. So the role has shrunk a little bit, I think, since the advent of FHIR, because you can make implementation guides, you can have also formal testing against the profiles, but I think there's still, for broader use cases, I think it's very useful. International use case, very useful, because otherwise, you get a more regional focus. It's good to have. For vendors that work internationally, it's very nice to have something that works in a global setting, at least for 80-90%.
Maybe a nice example of an EHA profile would be the MHD profile, which is actually kind of a FHIR plug on top of exchanging documents in the XDS environment. So the MHD profile describes how you could use FHIR to plug into an XDS network.
I'm checking the chat every now and then. There was a question earlier. I will try to bring it up, I'll try to read it out. This one was from Freek from Polen also. The question is FHIR in any way opinionated on how to properly store it? The image of the entities referencing each other looks a lot like a graph. which might call for a graph database. Though within the healthcare sector, I'd expect traditional relational databases are more prevalent. Are there any open source or reference implementations of storage? Any takers for this question?
So the HealthTech JPA server stores FHIR resources in a relational database. And in fact, even the textual representation of the FHIR resource. And it indexes a number of elements that you want to have indexed. So it's a very quite simple schema, in fact. Having graph databases, I think, would make a lot of interesting use cases possible, queries. But of course, it depends on how how much relationships you want to model in practice. So far, I really like graph databases. But if you want maybe reach some scale, I'm not sure if graph database would be the best choice. And we have not really missed it so far. But it's definitely interesting storage option.
And we also, in our FHIR server, we also use, we have an option to use relational databases or to use, for example, MongoDB, which also just stores the blob and then has indexes on top of it. So for each resource, it's just a blob with indexes on top of it to retrieve it, which works really well as well.
So I think the representation of FHIR resources would mimic more documental databases than relational. It looks like it's really a fit for it.
Yeah.
But we too like relational databases in order to have more stability on it.
Mm-hmm. Yeah, I can imagine. I mean, most of our customers do as well. They prefer the relational databases.
Yeah.
I just wanted to add that FHIR is designed to be an exchange standard, and it is being used by quite a lot of people as a persistent layer. And I think the FHIR spec itself also has some specs about it, or at least says something about it. And I guess it also refers to the GraphQL link somewhere. But keep in mind that it is designed as an exchange standard first. So I found it very interesting to see in the presentation that you switched over to using it actually for an exchange standard and having internally align it very well. But I think that's a very natural flow with this standard.
I see there's a new question from the audience, specifically to Walco. You listed the changes to the questionnaire resource in the different FHIR versions. How does that impact your product development and product design?
Wow. Okay, that's. I think we can have a separate meetup just about the questionnaire resources. I think it's a pretty complex topic, but I think I would like to mention two things. So first, we started using FHIR server as a store for the medical data, so everything that's related to patient data. We didn't store the questionnaire itself. That we changed in the second iteration. Because questionnaires evolve, so we have a medical content management system, but they use versions, but the versions can evolve when a patient answers a questionnaire at moment 1, 2, or next year. So we decided we really need also to store the questionnaire next to the questionnaire responses. So that's one iteration. And another important element of the follow-up iterations were and that's why I think using maybe custom data model for questionnaires was maybe a better idea. Is there's a lot of there's logic related to questionnaire flow, how you go from one question to the next, and the answer types. And answer types, they end up being very specific to the app, and not so much really interesting as a component of the medical record. So I think that's a split that we also wanted to make, have the display of the questionnaire responses or response options independent of what we store in the medical record. But I think it's worthwhile to have a separate session on it for sure.
Yeah, so I have a question about it quickly. Do you also looked at the international implementation guide for questionnaires?
Unfortunately not, no. Yeah.
They also have lots of different extensions for all kinds of stuff. And we also have a questionnaire information standard by NICTIS.
Yeah, I think last year a lot happened in this area, but I have not caught up myself on that. I think it would indeed be good if those things were standardized, but maybe you need kind of 2 layers of modeling to make it work 100%. But I think there's standardization also on the type of content in questionnaires, like prom questionnaires, and I think that's also something we're looking at now. Yeah,
it's also very hard, I guess.
Yeah,
that's something NICTIS at first declared out of scope. We're not trying to.
Yeah, I now understand why.
I'd like to have 2 more questions, and then I think we're going to wrap up. I see a new question from Freek again. Related to the backwards compatibility, are new versions being developed? By whom? And what will change about the standard in future versions? How fast are these developments going? So there's a lot of questions there. I'm assuming this is about FHIR versions.
Specification are normative. So, for example, the patient resource is a normative thing. It won't change. The next FHIR version, well, maybe it will add some fields, but it will be backwards compatible with 4. But every now and then, so R5 is like, I think, maybe every 2 years or something, you can say there's a new version of FHIR that's now. I don't think that's something that Hl7 standardized, that gap, but I think every 2 years or so there's a new FHIR version coming out, and that will change some elements, some resources, will add some resources. But for example, the REST specification is also normative, so that won't change anymore. That's, I think, really important. I think the main components of FHIR are now like set in stone or normative, and only additional stuff or like stuff that's mainly, well, not the main resources will be changed or added. And I see 4 as a really, FHIR R4 as a really grown-up standard already. So I think you can safely use it and not be afraid of 5.
Yeah.
One might think that this meetup is sponsored by FHIR. It is not, but maybe it begs the question: are there any main competitors out there for FHIR? Competing standards, to your knowledge?
Well, I'm OpenEHR, but it's
a different approach.
Yeah, that would be my first guess as well.
But it is more closely aligned than
And they complement each other as well. OpenEHR is more, they focus more on the data model and don't have a really strong exchange format like FHIR has a REST component. So I think OpenEHR is more about storage than exchange.
Yeah, I think they kind of have the concept of emerging interoperability. Like if you have a common data model, then the interoperability will be emergent property from that. But I don't really believe in that.
They try to tackle it at the source.
I think it helps. So that's also why I've stressed, with development of our own data model, we keep FHIR very closely in mind, and we test also that there's compatibility. But I don't think it just comes on its own, the interoperability aspect of it. I wanted to mention one thing, and that's around the FHIR versions, and that's we want MedMy for version 4 desperately.
We are working on that, so that's it's coming up. But we first start out with our new what's now happening in the Netherlands is ZIP 27, and based on STU3, Standard for Trial Use Free, the previous version. And we thought, like, if we're going to R4, we can also depend on like the newest data model, which would be ZIP 2020, and we're creating FHIR profiles for them, which are pretty far away. And if you have input, please go to the chat.fhir.org to think along. Where feedback is always appreciated. And once that's out, then it needs to be incorporated in the information standards and such. But
it's a really long process because every part moves always.
And this time we are really focusing on high quality and making everything very consistent. So because in the beginning it was also a bit of trial for us, because the Netherlands is quite first in a lot of things, especially also in FHIR. So we've learned a lot of with the previous creation of those FHIR specs, and this time it needs to be spot on.
And all the stuff we learn in the Netherlands is also, a lot of stuff actually being put back to the FHIR specification, which then improves on itself. So R4 has a lot of improvements that we tackled in STU3, which was...
We started out in DSTU2, version 4. And also a nice addition is the way of versioning FHIR profiles is also originated at Hl7 Netherlands, where we decided like how do we version like this whole bunch of FHIR profiles, and we went then to the Hl7 international community and said like, hey, we have a problem, and a year or two later we've got the FHIR packages way, which uses the technology developers all know from NPM stack, or that you actually can have packages that version with dependencies to other packages they're using. That's being applied to FHIR profiles as well, and it's being adopted, and the tooling has been incorporating that as well. But that's also originated in the Netherlands, because we were maybe the first to actually did so many profiles next to Argonaut.
I think we are about out of time. I would like to wrap up this meetup by thanking everyone who has joined us. Sadly, this time it was still online, but I'm sure for future meetups we will have the opportunity to meet in person. I'd like to thank all our speakers for the great talks today and the nice discussion at the end. And I'd also like to give a shout out to our technical crew for making this this smooth experience on an online meetup. We will send out information, the slides, and other details that we discussed just now for those interested. For now, thank you once more, and hopefully we'll see you for the next meetup.
Yeah, thanks.
Thanks for listening.